طيب، بسم الله الرحمن الرحيم. الليلة مواصلة في سلسلة المحاضرات. معنا دكتور سعود سلطان. دكتور سعود سلطان حيقدم لنا محاضرة عن الاسسمنت اند مانجمنت اوف الكحول ابيوز. يتفضل دكتور سعود. هنا انت ممكن تبتدي تعمل الشير للسكرين من عندك، ومايكروفون از يورز. في مربع اخضر.
اوكي سامعني كده؟
سامعينك.
اوكي السلام عليكم، مساء الخير. انا سعود سلطان، كونسلتنت ليزون سايكاتريست في ايست لندن. انا اخترت التوبيك دي assessment and management of alcohol misuse because it's a very common issue at my workplace in liaison psychiatry in particular, and I'm sure it will be the same for wherever you're working. Alcohol is always an issue. So I'm not going to tell you something you don't know already. Just consider it as a refresher, and we'll go through some slides. Hopefully we'll finish within 1 hour. And maybe we'll have opportunities for questions at the end. Okay, we'll make a start. So I thought I would start with the history of alcohol. Alcohol has been around for a very long time. And people used to make ferment grains, fruit juice, and honey for many, many years. It existed in early Egypt civilization, and it's being said that people who built the pyramids were paid in alcoholic beverages rather than being paid by money. So there is also evidence that it was around in China before around 7,000 BC, and also in India. They made it from rice. And the Babylonians, with the old civilization in Iraq, were also had a wine goddess around 2,700 BC. An ancient Greek, one of the first ancient Greece, one of the first alcoholic beverages to gain popularity was mead, and fermented drink made from honey and water. And actually, the Greeks were the first to warn people against excessive drinking. So that's the Greek wisdom for you from old civilizations. Also, in several Native American developed alcoholic beverages, variety of fermented beverages from Andes region to South America, where they're created from corn. And as you know, corn is still a very essential crop in South and Latin America. They also made it from grapes and apples. So this is just a quick historical background about alcohol. And as you can see, it's one of the oldest beverages that has been around for many, many decades and centuries. So when can alcohol or using alcohol become a health hazard, or how much is too much? So the current recommendation by the WHO, and here the NICE guidelines, and indicates that the maximum amount of alcohol units that an adult can have is 14 units per week. And it's also preferred that if whoever is drinking up to 14 units, to spread it over 3 days rather than having it at one go, or what's so-called binge drinking. For young people, of course, an alcohol-free childhood is the healthiest and the safest option. So children should not really be drinking, but unfortunately, we see them fairly regularly here. People presenting to A&E with alcohol intoxication. And for pregnant women, it's the same principle. So pregnant women should not consume any alcohol to keep the risk low. Drinking in pregnancy can lead to various complications to the baby, and the more the patient or the person drinks, the greater the risks to the baby. So they say the risk could be small if a woman has drunk only minimal amounts of alcohol, but it's preferred that they don't drink at all during pregnancy. So in this table, I summarized the risk associated with alcohol. Low risk is up to 14 units per week for both men and women. Increasing risk is 50 units for men and 35 units for women. High risk is more than 50 units for men and 35 units for women. And actually, these recommendations have been regularly updated. I remember when I first started working in psychiatry, it used to be 28. The low risk used to be 28 units per week. And I think following research and they decided that it's safer to reduce it to 14 units. Here are some examples of what unit of alcohol mean. A small shot of spirit, that is either whiskey, vodka, brandy, these are all spirits. A small shot is equal to 1 unit. A can of lager, beer, or cider, 44 ml, amounts for about 2 units. A pint of higher strength lager, and a pint is around 650 ml, roughly. It's equal to 3 units. So this is just an idea. If someone comes to the accident emergency and tell you I drink 6 pints, this is a commonly used measure here in the UK. It's a pint. People talk in pints rather than liters. So you know exactly how much they're drinking and whether they're within the safe limit or not. Again, a standard glass of red, white, or rosé wine is around 2.1 units, and a large glass of red wine is around 3 units. So this is just to give an idea. Of course, if the alcoholic drink is made outside the factories, it's made locally, as might be the case in Sudan, it's very difficult to first of all to know what is the concentration of alcohol in whatever the person is drinking, and secondly, it can be mixed with other chemicals and stuff that we don't really know, because there is no control of the manufacturing process. So yeah, this is what I've just said in pictures, similar to the table we just went through. Now, we all talk about alcohol dependence, and the standard in alcohol dependence is ICD-10 or the DSM-5 now. And I think the criteria are pretty similar. They're basically based on what used to be called the Edwardian criteria. And we have these 7 criteria: withdrawal symptoms, if someone is getting withdrawal symptoms; compulsion to drink; difficulty in controlling alcohol consumption; once they start, they can't stop; and also alcohol tolerance, as by time goes by, the person will need more bigger amounts of alcohol to achieve the same effect. And also they start to neglect alternative pleasures and try to become isolated at home, with alcohol taking prime over any other activities. And also, they persist with drinking despite clear evidence of harmful consequences. For instance, these consequences could be medical, could be social, could be family, could be employment, but they still carry on drinking. So if anyone has 3 or more of these criteria, we can safely say that they are alcohol dependent. Here are some epidemiology of alcohol dependence. Age and sex ratio, male to female, is 4:1. It's more common in men. High rates in urban areas. People in villages and rural areas tend to drink less. More common in divorced or separated. Lowest in the middle social group. So it's the alcohol consumption is higher in the lower social group and in the upper social group. It's also found that 35% of homeless people have alcohol disorders. There is high risk occupational groups, including doctors, entertainers, those who manufacture or sell alcohol, and frequent overseas travelers. This group of people found to be at high risk of becoming alcohol dependent or abusing alcohol. Here's some epidemiology from UK. There are, if you can see from the graphs here, the graphs are generally very stable over the years from 2007 to 2018. These are the numbers of people who presented to hospital with alcohol-related problems. About 300,000 presented with partly attributable conditions. With total number of admission is 400,000. Partly attributable conditions around 200,000. And 100,000 of wholly attributable conditions. That's purely alcohol problems. But we'll give examples in a minute. So these are some examples here. Wholly attributable examples are mental and behavior disorders like intoxication or withdrawal or whatever presentation they come up with. Other wholly attributable conditions, including alcohol liver disease, toxic effect of alcohol, intoxication, etc. Partially attributable these include unintentional injuries, cardiovascular disease, respiratory infections. TB, of course, is fairly common in people with alcohol disorders. Intentional injuries, that is self-harm, digestive disease, gastric ulcer, etc., etc. Disease of the nervous system, pregnancy and childbirth, that is unintentional pregnancy or unintended pregnancies and childbirth, or unplanned rather, and also infectious and parasitic disease. So these are some figures from the UK. So our next stop is about assessment. So how do someone presents to your clinic and tells you that they have a drinking problem? Of course, most of them would not admit it initially. And when they feel that the situation is getting out of hand, out of control, they start to seek help. And the system here in addiction clinics, they will not accept patient unless they self-refer. So if I send someone, we can only give them the details of the clinic and contact numbers and so on, but referring someone does not necessarily mean that they will be seen. So the first step is to seek help. So in the assessment process, you need to know when did they first started drinking, at what age. Of course, the earlier they start, the poorer the prognosis. Also, you need to ask about regular weekend drinking. Do they drink every weekend, or do they drink every evening? Do they drink daytime or at night? Do they drink alone with other people? And also, more importantly, it's important to ask about early morning drinking. people who drink or have an eye opener, as they call it, they usually will start to show withdrawal symptoms. That's why they start drinking early. So you also need to ascertain the consumption at each stage, noting the type of beverage and quantity consumed. So because you need to have an estimate, because if anyone with daily intake over 15 units will need to go detoxification. So it's very important to calculate the actual amount consumed. You also need to ask the patient to give you a detailed description of their day from the moment they wake up. Tell you what do you do? Do you go to work? Do you stay at home and carry on drinking? What exactly happens? So it's very important to have that description. And again, it's important to have the timing and consumption of the first drink. And it's also important to ask them about their drinking and what do they think about it, because this is a beginning or the starting point for treatment. If the patient does not see there is a problem, then there is no point in continuing. It's highly unlikely that they would drop out of treatment and start drinking again. So the willingness to engage in the treatment is really important. Again, after you finish your history of alcohol, you need to go through family history. As we know, there is some heritability associated with alcohol. So there is a genetic element. If there is a family history of heavy drinking, whether it's of parents, siblings, etc. And then you need to ask about the personal history, personal occupational history, as well as sexual marital history are very important, because it will show the consequences of abusing alcohol. How does it affect the person in his family relationship, in his work, in his marital history? And there's lots of social complications related to alcohol misuse. And also because they drop out of education or work, then they start to suffer financial problems, quite often become homeless. It's also important to ask about the past medical and psychiatric history. As we know, in the psychiatric history, it's important to ask about anxiety, depression. Most psychiatric symptoms are associated with high percentages of alcohol dependence and misuse. In the medical history, you need to know whether the alcohol has affected them medically. If they have liver problems, they have blood disorders, gastric problems, etc. So it's important to ask exactly. Even high blood pressure, cardiovascular disease, they're all associated with excessive drinking. So you need to get a detailed history about the medical and psychiatric history. It's also important to ask about the forensic history. People who dependent or abuse alcohol are quite more likely to get in touch with the law, whether it's drink driving or shoplifting. They go to shops and steal alcohol if they can't pay for it. Drink driving, road traffic accidents, etc. Some of them are also involved in criminal activity, more severe criminal activities, not just shoplifting. It's also important to ask about the pre-morbid personality, because you need to have a baseline before, to compare how, some people will tell you I was quite a sociable person. I had lots of friends, but this is all gone. And I'm now just isolated at home, hitting the bottle. So here are some areas that need to be covered in the assessment. It's also important to take a detailed treatment history for alcohol dependence, whether they had detox in the past, detoxification program in the past, whether it's in a general hospital. Nowadays, In the UK, I don't know about other countries, but in the UK, most of the detoxification is done on medical wards and it's supervised by the medics rather than psychiatrists. People with less, we'll talk about that in more details later. Detoxification can also be done in the community. And this is for milder cases. Just excuse me, just 1 minute. I just put the lights on. It's getting a bit darker here. Yeah, sorry about that. So in the treatment history, you need to know whether they had have undergone detoxification and whether they're receiving any treatment at the time when you saw them, whether it was inpatient or outpatient, because inpatient detoxification and rehab is an indication for the severity of dependence. Particularly people who go into residential rehab, this is long-term treatment for people who have severe alcohol dependence. And also we need to ask about if they're on treatment for any medical conditions or psychiatric conditions, whether it's antidepressants or any other medications they're taking. Then you do your routine physical examination. As I said, this is all nowadays done by the physicians. We rarely get involved in this. And you carry out investigations, including full blood count, urine electrolytes, liver function test, including GTT, PT, and urine drug screening, because quite often there is another comorbidity of substance misuse associated with alcohol. Now, more specific tests include GGT, and GGT has a sensitivity of 80% and specificity of 80% also. So it's a fairly reliable test. If someone scores high GGT, it's likely that they are abusing alcohol or drinking in excess. Sensitivity, are we familiar with the term sensitivity? Sensitivity means it's the ability of test to detect the positive results, and specificity is the ability of the test to rule out any negative results. So 80% is a fairly decent percentage, and as I said, it's a fairly sensitive test to pick up people who are drinking in excess. MCV is good as is not very good at sensitivity. It can miss out about 50%, but it's good at ruling out alcohol misuse by about 70%. AST or liver enzymes, including alka-phos and AST. Again, AST sensitivity is very low, but the specificity is also reasonable. Alka-phos, as we know, is associated with obstructive liver disease, and about 60% of sensitivity and 50%. So it's not a very good test to detect alcohol dependency. So you add your results, because the results alone will not tell you much. You have to incorporate it with your history and physical examination to have a reasonable idea of what's going on. There are assessment tools as well, can be used, structured assessment tools. I mean, we all know the CAGE questionnaire, and I'm sure everybody here is familiar with it. C is for, have you thought about cutting down? A, do you get annoyed when people criticize your drinking? G is for guilt. Do you feel guilty about drinking? E is, have you, it will come in a minute. So the CAGE questionnaire is a screening questionnaire. You can ask any patient in the clinic. Yes, E is for eye opener. Do you get an eye opener in the morning when you first wake up in the morning? So there is audit. It's a 10-item questionnaire. I wish if I had samples here, but I'll try to find some and maybe send it to Yasser. Severity of alcohol dependence questionnaire, SATQ, is another questionnaire with about 20 items. And so you finished your assessment, and we in the next section we will look at the complications of alcohol misuse in all aspects of the patient's life, medically, socially, and psychologically. So as you can see, Homer Simpson here. He's just finished his drink, and he could barely move. So here is just a representation of which organs are affected by alcohol, including the brain, esophagus, heart, liver, kidney. Almost every system in the body is affected by alcohol. In more details, here are some illustrations. 100% of alcohol use disorders, 18% of suicide is associated with alcohol, 18% of interpersonal violence, 27% of traffic injuries, 13% of epilepsy. These are all associated with alcohol. Liver cirrhosis, about 48% of cases of liver cirrhosis are attributable to alcohol. 26% of mouth cancers are also related to alcohol. Pancreatitis, 26%, 20% tuberculosis, 11% of colorectal cancer, and about 5% of breast cancer, 7% of hypertensive heart disease. So as you can see, it can affect almost every part in the body, it's very important to address the misuse issue before things get worse. Right, so to go in more details, we can see that neuropsychiatrically, it can cause memory blackouts. The person will wake up the following morning and will have no recollection of what went on the night before. Pathological intoxication, they become increasingly drunk. They start to act out of character, getting involved in fights, etc. And then more severe cases, in particular withdrawal, people can present with delirium tremens, and we'll talk in more details about that. Depression, phobic anxiety, suicide attempts, pathological jealousy. Maybe our colleagues in forensic can talk more about pathological jealousy or Othello syndrome. Sexual dysfunction, personality changes, eating disorders, and alcohol hallucinosis. So all these conditions can occur as a consequence of excessive alcohol use. Socially, can cause marital breakdowns, occupational financial problems, and forensic history, as we mentioned earlier. Physically, again, gastritis, hepatitis, cirrhosis, pancreatitis, peptic ulcer, esophageal varices, esophageal carcinoma, seizures, cognitive impairment, peripheral neuropathy, cerebellar degeneration, anemia, cardiomyopathy, myopathies, injuries, etc. Alcohol withdrawal syndrome, acute withdrawal of alcohol starts with tremors, nausea, profuse sweating, mood disturbance, fearful or depressive. They can be extremely anxious as well. Hyperacusis, they hear noises louder than they usually are. Tinnitus, itching and muscle cramps, sleep disturbance, and perceptual distortion. And in severe cases, they may go into delirium tremens. Delirium tremens is the most severe form of alcohol withdrawal. We'll talk about it in more details. So the alcohol withdrawal starts in the somatic symptoms start in between 3 to 12 hours after last drink, and symptom peak at 24 to 48 hours. Within a day or two, symptoms will become more severe, and the usual duration is, whether you treat it or not, between 5 to 14 days. They will resolve completely. Seizures can occur between 12 to 18 hours. Adequate benzodiazepine cover is really important in patients who are prone to develop seizures when they are withdrawing of alcohol. The DT or delirium tremens starts 3 to 5 days. It develops in about 5%. And this is, by the way, is a medical emergency. The mortality is anywhere between 10 to 20% of untreated, and it's a medical emergency. They should be immediately admitted to a medical ward and treated. Here are some general principles from the NICE guidelines, general principles. I'm not going to go into details. You can read them later if you have time. So the most important point here is the patients who are selected for admission, hospital admission, or inpatient detoxification. These are, number one, people are thought to be at high risk of developing alcohol withdrawal seizures or delirium tremens. They need to be admitted to hospital immediately. And also young people under 16, they should be treated in an inpatient setting. And also certain vulnerable groups who are in acute alcohol withdrawal, for example, those who are frail, have multiple medical problems, cognitive impairment, lack of social support, you also, or have learning difficulties, you also admit them for detoxification. And also for people who are not admitted, you offer advice of avoiding sudden reduction of alcohol intake and about how to contact the local alcohol support service. So this group, 3 groups, is best to be treated in an inpatient setting. And if you are sending the patient home, just advise them not to stop suddenly and give them the contact details of their nearest alcohol service. So acute alcohol withdrawal, there are different ways of treating. The most commonly used one is a fixed dose reduction regime, and we are all familiar with this. You start with a high dose of benzodiazepine. In the UK, we mostly use chlorodiazepoxide, alternatively diazepam. Suitable for community non-specific and uncomplicated cases, basically. And quite often it's done at patients' own home. Or they go to the clinic every day, receive their benzodiazepine, wait there, they check their vitals, and then send them home. Should be started on a dose of after assessment of severity of alcohol dependence, and is tapered to 0 within 5 to 7 days. So here are 2 examples. So day 1, this is someone with maybe mild to moderate alcohol dependence. You start on 80 milligrams of chlorodiazepoxide, reduce it day 2 to 60, day 3 to 40, day 4 to 20, and so on, and you stop it at day 5. This is more prolonged regime, up to 10 days. These are for people who have more severe dependence or have more severe withdrawal symptoms. So these are the mostly used here. And there is another way of doing it, is the symptom triggered regime. So in this case, for managing assisted withdrawal in patients with complications in a specialist alcohol inpatient or residential setting. So this is not for the community. Regular monitoring of vitals is very important, and the level of consciousness, as well as the withdrawal symptoms. Medication is given only when the withdrawal symptoms are observed. So a typical symptom trigger regime would be chlorodiazepoxide, 20 to 30 milligrams hourly, depending on whether they're having symptoms or not. So if they're controlled, you start to stop the dose gradually and reduce it from day 2 onwards. So this is a different way of doing it. Now there is also the front-loading regime, and this is used in medical inpatient units. We start with an initial loading dose of chlorodiazepoxide, 100 milligrams, followed by further dose between 50 to 100 every 4 to 6 hours until light sedation is achieved. The patient is monitored every 2 hours using SIWA, which is an alcohol withdrawal scale, and until the withdrawal symptoms alleviated. Front-loading regime is contraindicated in advanced liver disease and COPD or following a head injury. Here is a quick calculation of the equivalence of different benzodiazepines that can be used. Chlorodiazepoxide, 50 milligrams. The half-life, is equivalent to about 5 milligrams of diazepam. The half-life is about 5 to 30 milligrams, 5 to 30 hours. And active metabolites can stay in the system for 36 to 200 hours. And the same is for diazepam, 21 to 50 hours is the half-life. And the active metabolites can remain for as long as 200 hours. Lorazepam, 0.5 milligrams to 1 milligram, it's about 10 to 20, and it's the shortest acting benzodiazepine that is used in alcohol detox, and it's usually used for people with chronic alcohol disease because of the short active. You don't want to use a long acting one, so that you do not want to impact the liver. General treatment: you treat the dehydration, pain, nausea, and vomiting, diarrhea as usual. It's also nowadays, it's routinely, people are given routinely IM or IV. You call it here Pabrinex. It's a combination of thiamine, vitamin B1 and 6 in one shot. So all patients presenting with alcohol withdrawal, they will receive that. Psychological interventions include cognitive behavior therapy, focus on alcohol-related problem, usually consists of 1 60-minute session per week for up to 12 weeks. Behavior therapies, alcohol-related problems should usually consist of same 60 minutes up to 60-minute session for 12 weeks. Social network and environment-based therapies focused on alcohol-related problems. Again, behavioral couple therapy is also helpful. So there are a wide range of, there's motivational interviewing as well. So a wide range of psychological interventions available for. And then pharmacological intervention for prevention, basically, for relapse prevention include acamprosate. We are all familiar with it. And naltrexone is also being increasingly used. Disulfiram is the most famous one, and it's not being used very often nowadays. You start treatment at least 24 hours after the last alcohol drink. Usually the dose is 200 milligrams per day for service users who continue to drink. The whole idea of the disulfiram is if patients start drinking while taking it, they will have a severe reaction, a very unpleasant feeling. They feel very sick, and that is thought to be a deterrent for them not to drink again. So you need to check the liver functions, etc. Here is a more inclusive list of medications that are used. Some of them have strong evidence, some of them have very little evidence. So you can have a look at details maybe later. Complications associated with alcohol withdrawal: seizures. Alcohol withdrawal can precipitate seizures, but other organic causes need to be ruled out. So if someone presents with a seizure with alcohol plus alcohol misuse, that does not necessarily mean that it's due to alcohol. So you need to have the normal investigations, especially with those who are presenting for the first time. They need to be investigated just like any other case of epilepsy or possible epilepsy. Long-acting benzodiazepines such as diazepam is effective in preventing seizures in alcohol withdrawal. So It's either some people add anticonvulsants, like whether sodium valproate or carbamazepine, for people who are prone to develop seizures due to alcohol withdrawal. There is no need to continue the anticonvulsant in the long term if they have been used to treat alcohol withdrawal and related seizures. So as soon as the patient complete their detoxification program, you can safely discontinue it. Now, delirium tremens, as I said earlier, it is a medical emergency and a toxic confusional state that occur when alcohol withdrawal symptoms are severe and considered to be a medical emergency. Symptoms peak between 72 to 96 hours after last drink. Risk factors include long history of dependence, multiple previous admissions, old age, and history of DT or alcohol-related seizures. The classical triad of symptoms include confusion, clouding of consciousness, and vivid hallucinations. Clinical features also include paranoid delusions, agitation, sleeplessness, and autonomic hyperactivity. Patients should be managed in a medical setting where IV diazepam can be given, medical disorders treated, fluid and electrolytes replaced, thiamine and other vitamins administered parenterally. Wernicke's encephalopathy is another complication associated with alcohol withdrawal. Is caused by thiamine deficiency with acute degenerative changes in the thalamus, hypothalamus, and mammillary body. Thiamine is required to utilize glucose. A glucose load in a thiamine deficient patient can precipitate Wernicke's encephalopathy. So Wernicke's encephalopathy, if the patient presents with possible DT or possible Wernicke's encephalopathy, it's very important not to give them any glucose initially until their confusion is controlled. This can precipitate Wernicke's encephalopathy. And the signs are confusion, clouding of consciousness, ocular pulses, staggering gait, peripheral neuropathy, memory disturbance. Management, as I said earlier, parenteral thiamine to all high-risk patients as prophylaxis. And as I said earlier, it's given routinely now to all patients presenting with alcohol withdrawal. And it must be offered before glucose is administered because of the risk of precipitating Wernicke's encephalopathy. Low-risk patients with no neuropsychiatric complication and adequate diet should be offered oral thiamine of 300 milligrams daily. But again, that is questionable now because some results or some studies have indicated that in the thiamine absorption via the GI system is diminished if someone is an excessive drinker. So you have to make that judgment, but it will not do them any harm anyway. Now, Korsakoff syndrome or Korsakoff psychosis is residual state following Wernicke's. So if Wernicke's is not treated, people go into Korsakoff. And this is a almost permanent or irreversible condition. I maybe I have seen only 1 or 2 cases on medical wards. They present with inability to form new memories and retrograde amnesia. And they start to confabulate, making up stories and things. And I remember we had this patient who had Korsakoff, and he started talking about that he used to run a business of £2 million in car trading, and that he was a famous radio presenter, etc. So we all thought he's confabulating. So for some reason, the registrar who is working with me Googled his name. And guess what? It turned out to be true that he had actually this business and he used to work for a radio station as a DJ. So, but he was confabulating about other things, not only this one. A relative preservation of other intellectual functions and clear consciousness. Peripheral neuropathy, again, is a residual problem with this group of patients. A small percentage may improve by continuing thiamine treatment, but overall, you will not see much improvement in this group of patients. Now, other complications related to alcohol include alcohol dementia. And this is a mild to moderate cognitive deficit, including impaired memory, judgment, and personal social neglect, and paranoia. Rarely occurs before the age of 40, and females are more at risk. It's usually accompanied by other CNS and liver damage. So this is basically for chronic drinkers. It's also associated with evidence of cerebral atrophy, especially frontal lobe. Symptoms can improve by abstinence. Prognosis poor prognosis is generally associated with someone who has established brain damage, whether it's due to alcohol or not. Because when that part of control is gone, then the drinking becomes problematic. If you have comorbid psychiatric disorder, again, you are more likely, especially antisocial personality disorders, you are more likely to have a poorer prognosis. People who have criminal history, and again, this group may include also antisocial personality disorder, people with low IQ, poor social support, and low motivation. And also, if someone has where the longer the duration of alcohol dependence continues, the poorer the prognosis is. Thank you. I think I'm done now. So if there are any questions, I'm happy to take any.
Thank you very much, Dr. Abdelghani. You can take the microphone.
سعود السلام عليكم. ياسر السلام عليكم والجميع. شكرا سعود for this very nice and fruitful حقيقة presentation. سلام لكل participants. I think today we have approximately 52 or 53 participants including ياسر وسعود. فيهم some specialists and some consultants.
سامعينك.
ايوه. طيب يا سعود، يس بالنسبه للالكحول يونتس طبعا it is changeable زي ما قلت. انت قلت لما كنت تريني كانت 28. انا لما كنت تريني كان for males 21 و for females 14. وعارفين طبعا الديفرنس because الفيميلز they are less tolerant للالكحول. الانزيم بتاع الكحول ديهيدروجينيز عندهم اقل من الميلز، فبالتالي الافكت بتاع الالكحول عليهم بيكون اكثر. فكانت 14 for females per week و 21 for males per week. الحاجه الثانيه زي ما ذكرت
سوري انا ظاهر اقدم منك يا عبد الغني، لانه انا قلت 21 دي برضه.
ايوه كانت 28 بقت 21. نحن اخذناها 21 على كل حال، فكانت 21 و 14. الحاجه الثانيه which you have mentioned yourself about traditional alcohol اللوكال العرقي. نحن around 10 or 15 years ago عملنا survey or research على الالكحول على العرقي، وكان معي دكتور الجمل هو برضو في الشرطة وهي فارماسيست وفي المباحث الجنائية كان وفي المعمل الجنائي. فكان بيرسل ناس الشرطة يمشوا لستات العرقي وياخذوا منهم سامبلز ويقول لهم نحن ما حنعمل لكم أي حاجة بس ادونا. طبعا الستات العرقي قالين ناس البوليس دي جايين يشربوا العرق يشربوا من كل واحد بياخذوا باغة وعملوا له اناليسيس في الادله الجنائيه في المعمل الجنائي. لقوا الغريبه زي ما انت قلت في اديتيفز كثيره، يعني لقوا في بنج الحصين، ولقوا مويه بطاريه، وفي حاجات لقوا في سفنجات في العرق، ولقوا نبات كده ما عارفه يعني سكرونه ولا شنو، يعني بيخطوا حاجات كثيره الستات دي. اخذنا سامبل ما بتذكرها كم والله، لكن عملنا الانفستيجيشنز الروتين، السي بي سي، الام سي في، الليفر فانكشن تيست عملناها في اكثر من 99% لقينا الليفر فانكشن تيست نورمال، وناس بيشربوا عرقي بكميات كبيره حقيقه. فللاسف الداتا بعد ذاك ضاعت، ما اعرف خلوها وين، ما قدرنا نعمل مور اناليسيز لها، لكن دي كانت زي preliminary results شفناها. السؤال بتاعي بقى زي ما انت قلت، هو طبعا الديلوجنال جيلسي اللي هو الثيرلو سيندروم، الهالوسينوسيس، الكورساكيف سايكوزيس، ديبريشن، انزايتي، دي ريبورتد كثير. لكن have you come across alcohol-induced psychosis, schizophrenia-like psychosis, أو mania-like psychosis؟ لأنه في السودان شفناها الحقيقة. فهنا في التكست ما ظاهرة كثير، لما مركزين أكثر شيء على الديلوجنال جيلسي، انزايتي، ديبريشن، ودي كثيرة، الديبريشن والسوسايد كثيرة. وشكرا لك يا سعود.
العفو عبد الغني. في الحقيقة يعني هنا لأنه الناس كلها بتشرب it's very difficult. بعدين quite often people are not open about the amount of alcohol they consume. Usually لما واحد يقول لك بطوال بنضاعف الكمية اللي بيقولوا لك، لانه بيشوف الليفر فانكشنز حقته وبيشوف باقي الانفستيجيشنز indicate heavy drinking، لكنهم بينكروا طبعا. فبالنسبه للسايكوسيس ما مرت علي انه psychosis triggered by excessive alcohol use. Maybe it's more than a comorbidity. يعني هو اكثر شيء بنشوف في ناس البايبولار disorder, manic patients usually on the first onset or first episode psychosis they بيكونوا elated in mood، بيكونوا high، بيمشوا يشربوا كتير، they spend money وكده. بعد ذاك بتبقى combination، انت ما you don't know which is which is which. يعني هل السايكوسيس بدا first ولا الاكسسيف drinking بدا first؟ it's very difficult. لكن purely كده someone who became psychotic due to alcohol ما شفتها هنا.
Yes, thank you so much. زي ما قلت لك في السودان في حالات شفناها الحقيقة، لكن برضو you cannot say إنه it's purely due to alcohol، لأنه أغلبهم بيضربوا البنجو معاه يعني. مع الكنابيس طبعا شفنا حالات كثيرة بتاعت الكنابيس بيجونا بسكيزوفرينيا لايك سايكوزيس. Thank you.
Okay.
أنا عندي إضافة في نقطتين. النقطة الأولى في موضوع الجي تي تي as a يعني screening test ولا مثلا as a common lab order. هو في الآخر لو العيان جاك وقال لك اعترف أنا he's a heavy drinker ما في لزوم للتست أصلا. يعني it's not going to tell you more than what you know. هي المشكلة في الناس that they don't tell you what's going on or they try to minimize. يلا الجي تي تي is going to be of helping. الحاجة الثانية هي على الكلوروديازبروكسايد. يعني في ميزة له ثانية جميلة غير أنه مثلا it's a long half life. الميزة الحلوة أنه الكالكوليشن بتاعته سهلة. إذا أنت عرفت مثلا الليلة الزول بياخذ كم يونت؟ بياخذ كم يونت مثلا في اليوم؟ مثلا بياخذ يعني 50 يونت في اليوم ولا بتاخذ مثلا 100، يعني على حسب اليونت انت you can translate الموضوع ده تماما للدوز بتاعت الكلوروديازبروكسايد. ما الكالكوليشن بتاعتها ما صعبة، فدي ميزة له لأن الناس بتحب تستخدم طوالي. في حتات ثانيه يعني حتى في امريكا لكن ما very common في مستشفيات they use alcohol to treat alcohol use disorder. يعني they use عديد كده بيجيبوا alcohol وبعدين بيدوا للعيان، يعني ما as a drink بس يعني as an IV. فبس يعني دي كان نقطتين داير اضيفهم. في سؤال عندنا هنا من رحاب. Could it be predictable that alcoholics who are at high risk of delirium tremens?
Yes, from the history, you will see that people who present with delirium tremens have a long and heavy history of heavy drinking. If someone is presenting for the first, it's very unusual to see someone presenting with delirium tremens for the first time. But most of them, yes, you can tell. Probably some of them would have had it before, and they present again and in a delirium. Usually they come to the accident emergency department, where this is where we see them. And we have a very good setup in the hospital. We have an alcohol worker who is completely dedicated to look after people who present with drinking problems. And most of the time they are repeat offenders that بيجوا severe withdrawal symptoms or delirium tremors.
عندنا محمد المبارك رافع يده. محمد, you can unmute yourself.
Okay, shukran Yasir. At the beginning, really, I would like to thank Saoud for this excellent, very thorough presentation. وكل participants بقول لهم good evening. فأنا بس إشارة للأخ عبد الغني أضاف نقطة جميلة جدا وأسارة، وكنت أتخيل الأخ سعود يغطيها برضه وعرض لها حقة الكوموربيديتي. أنا through my work here في الرقم الكحول وشغالة في الفورنزيك بتجي معظم الكيسز for us are comorbid. Apart from the physical, I mean with mental health. I doubt it ever. I haven't seen alcohol per se inducing psychosis unless they got hallucinations. Lakin we believe, this is seen by researches and empirical evidence, people with mental illness, they are more likely than the other general population to consume alcohol. So as the self-medication, as part of their problem, as the way of sorting problems, عشان كده that's why they present with depression and anxiety or with psychosis and alcohol-related problems. And all the services they have got, as Saoud says, they are having a proper alcohol services. Even the alcohol workers, they might cover all the areas of the assessment and the initial assessment. But the comorbidity, here where the psychiatrist is needed to have a very thorough assessment and history and proper mental state examination to treat. بالنسبة للunits, حتى هنا in England, الunit is very difficult to establish because unless likely ever البيشنت يديك units لأنه هنا دائما they use the pints. Well, a very interesting point, when you see alcohol and drugs, we have observed all the times over the years, the alcoholics, they tend to underestimate the amount of the alcohol they consume. Then we are not an alcoholic at all. As you go deeper, you discover they are really drinking too much. Opposite to the drug users, they tend to overestimate the amount of the drugs because they are expecting to have more replacement of methadone and Subutex and others. This is a point we will have to be very careful about. And those who are mentally unwell and they continue using alcohol to self-medication, they need to have another thorough assessment, even after a detox, just to make sure actually they are having a separate mental illnesses which require treatment for its own merits or just only alcohol. Well, thank you very much.
شكرا محمد. صحيح كلامك. alcohol is a very common comorbid. Almost 50% of psychiatric patients have also abused alcohol. So it's very important, even when you are in a regular outpatient clinic seeing patients, taking a detailed alcohol history is very important. Yeah, it is very common. And also very common in self-harm. Most people we see in ED who present with self-harm, whether it's taking overdose or self-injurious behavior, were also intoxicated during the episode itself. So it is very common.
عندنا سؤال في الشات وعندنا فتحية رافع يدها. السؤال في الشات الأول: should we hold disulfiram if the patient presented repeatedly to the hospital with unwanted effects, especially confusion and breathing difficulties?
Yeah, I think it will not be safe to continue, especially if the patient is insisting on going back to drink while taking the sulfiram. That means it's not working for them. So it will be safer to discontinue it and try other ways, whether psychological interventions or any other rehab, relapse prevention techniques.
Fathiya, you can unmute yourself.
السلام عليكم، شكرا على البرزنتيشن الجميل. عايزة أسأل، بعد مرات بيجينا بيشن في الحوادث بيكونوا هم يعني أوف الكحول فور 1 ويك ومانج في البيت، ما حصل له حاجة، هو بيجي في مثلا في المستشفى فور يعني فايزر مانجمنت. فأنا هل عندي المنطقة بقى السيف أنا ما أعمل له أدميشن في الفترة دي، لأنه هو طلع من كل الأورس تحت السيجر والكحول التريميناس وكلها، فهل أنا ممكن أعالجه أو البيشن مع psychologist بس؟
Yeah, if the patient is not presenting with any withdrawal symptoms, then yes, it will be safe to offer him follow-up and relapse prevention work. If they are not having any withdrawal symptom, then it's highly unlikely that they will need immediate attention. So I agree with you. Yes, it would be safe to offer them follow-up.
سؤال من الدكتور العزيز نادر مكي. Nader, you can unmute yourself. Nader, unmute yourself.
كده سامعني. السلام عليكم ورحمة الله.
وعليكم السلام.
الله يديكم العافية. أنا بتكلم معكم من ماليزيا، وإحنا أكشولي الآن شغالين في الكورس بتاع الأدكشن في الفيلوشيب بتاع ماليزيا هنا، واتطرقوا للموضوع الجميل اللي عرض الدكتور كتر خيره. وكان بس المداخلة إنه برضو عندهم نفس المشكلة والدايليما بتاعت اللوكال درينكس، وبيعملوها من الرايس، ودخلوا في أشياء كثيرة جدا إنها يعني حاجات تراديشنال وريليجيوس وصعب إنه يمنعوها من الناس. فمن الرولز ولا الحاجات اللي استخدموها من الترايلز بتاعتهم النالتروكسون، وطلع إنه فيري إفكتيف حتى في الحتة بتاعت الإمبلانتد نالتروكسون. فهل في أي يعني رولز ولا حاجة زي دي في يوكي ولا في أمريكا، ولا ما تطرقوا للحاجة دي خالص عشان تو decrease the craving؟
والله شكرا دكتور على السؤال. النالتروكسون مستعمل موجود، لكن بحكم ما اقدر اديك اب تو ديت يعني عن الموضوع، بحكم انه انا وظيفتي is a liaison job. يعني انا I see the patient when they present in the acute phase. بعد ما نخلصهم نعمل لهم الديتوكسيفيكيشن، when we finish we send them to the community alcohol service for follow up and relapse prevention. But yes, it has been used here.
انا اضيف من جهتنا احنا الانتي ابيوز اصلا في امريكا very rarely used عشان الديترنت سايد افكتس، عشان الفكره ذاتها يعني انك تبانش نفسك عشان لما تشرب، يعني it's not appealing. التو medications widely used هم الاكامبروسيت والناتريكسون. الناتريكسون is widely used اكثر من الاكامبروسيت. very effective, very helpful. وبعدين يعني في عنده كمان injection given once a month. يعني بتديها once a month and it can help with the craving for both alcohol and for both opioids. فدي ميزة هنا الناتريكسون، وهو ما غالي as a medication.
Yeah.
عندنا سؤال من عمر أحمد بابكر. Is there any percentage for accidental suicide or suicide by alcohol in general?
Suicide by alcohol, just accidental or suicide by alcohol, which one? Because if it's accidental, it's not suicide. So the first definition of suicide is the intent. This is if there is no intent there, then we can't call it suicide. But intoxication of alcohol can lead to death by some people get severely intoxicated, they have aspiration, and then they choke and die. Fortunately, it happened. I hope that answered your question.
I think he was asking if there is any percentage of.
No, I couldn't. You mean for death by severe intoxication or
suicide related to alcohol drinking?
Okay, so suicide related to alcohol. I couldn't give you an accurate figure, but I would say most people we see who present to ED with self-harm or suicide attempt in one way or another were under the influence of alcohol. So I would imagine there would be a high rate of intoxication during the attempt itself.
اوكي اذا ما في اي اسئله تاني انا افتكر ممكن نوقف الريكوردينج هنا.
لا ما في سؤال، ما سؤال، بس كومنت لو سمحت لي يا ياسر.
اوكي.
كومنت ومهمه جدا، ولانه لاحظناها في السودان وقال قبل سعود mentioned it. Delirium tremens is a medical emergency. لانه شفنا in some psychiatric hospital they have admitted a patient and then the patient developed delirium tremens and they kept the patient in the psychiatric hospital where there are no any facilities to help the patient. فأنا دائما حتى في كل الليكتشرز زمان في الامرجنسي سايكايتري بقول لهم delirium tremens ولا delirium in general is a medical emergency rather than a psychiatric emergency. Unfortunately, our medical colleagues and physicians, they think إنه delirium it's our job as a psychiatrists لأنه البيشنت يكون عنده sometimes hallucinations ولا delusion ولا bizarre or abnormal behavior طوال يقول لك ده would do psychiatry, and this is not right. Delirium tremens or any delirium is a medical emergency. Just this is a point اللي حبيت أقوله بالذات for our trainees عشان ما to accept and admit a patient with delirium in a psychiatric hospital. شكرا سعود.
عندنا سؤال أخير هنا من فتح العليم. In case of chronic agitated alcoholic patient with raised liver enzymes, can we use diazepam if short-acting benzodiazepines are not available?
Yeah, I think if the diazepam is not available, then you can use maybe smaller doses. Start with smaller doses and build the dose more slowly. It'll be safer. And also it's important to restrict the duration of treatment, not to continue for a long time. So try to adjust the dose depending on, and also to follow with a series of liver function tests while the patient is taking the diazepam. So you need to do it maybe almost daily liver function test.
بشرى عندك سؤال؟
يا السلام عليكم. شكرا ياسر وشكرا دكتور سعود على ال comprehensive presentation. يعني رغم ان انا جيت متاخر شويه لكن I can tell. وشكرا دكتور عبد الغني. Just it's not a question, it's a comment about the last question. If there is a severe liver damage, what medication to use? I think what we use here, and it's just easy to memorize by medication metabolized outside the liver, OTL, oxazepam, temazepam, or lorazepam in case of severe liver damage. The other quick comment is about if there is anything that could predict development of DT, in addition to what Dr. Saoud already mentioned, I think previous DT is the main thing, but hypokalemia and hypomagnesemia and low platelets, these one of the main parameters that we look for in cases of alcohol intoxication in general. Thank you.
طيب مشكورين جدا جدا، واذا ما في اسئله ثانيه افتكر احنا we stop the recording.